Hi, my name is Shannon Eonochs, and I'm a psychiatric mental health nurse practitioner. Today I'm going to be giving you a very brief overview of perinatal mood and anxiety disorders, or PMADs. Perinatal is the period of time from the time of conception to post-delivery. Mood encompasses depression, unipolar depression, bipolar depression, and psychosis. Anxiety includes generalized anxiety, panic disorder, postpartum obsessive compulsive disorder, and post-traumatic stress disorder. And disorder is anything that is intrusive in your patient's life. Many people, all people experience the whole range of symptoms, but when it becomes intrusive is when you want to do something about it. So first I'm going to talk about perinatal depression. 10% of patients experience perinatal depression during pregnancy, and 15% of patients experience perinatal depression during the postpartum period. The risk for perinatal depression is increased if the patient is living in poverty, and the risk for perinatal depression is twice as likely if the person experiencing the pregnancy is a teenager. Perinatal depression is the most common complication of pregnancy. While symptoms vary from person to person, symptoms most often include increased irritability, anger, sadness, crying, feeling fatigued, experiencing disrupted sleep and appetite patterns, feeling ashamed, hopeless, guilty, not being able to experience any pleasure in things that they once did, not having an interest in doing things, and possibly having thoughts of harming themselves or their baby. Risk factors for the development of perinatal depression include having a personal or familial history of depression, anxiety, or postpartum depression, having a history of PMDD, which is perinatal mood dysphoric disorder, or PMS, having inadequate support in caring for the baby, having financial stress, relationship stress, any pregnancy or birth stress or breastfeeding stress, being a mother of multiples, having an infant in the NICU, having thyroid imbalances, being diagnosed with any form of diabetes, experiencing a recent loss to include pregnancy loss, job loss, house move, not having enough food. All of those things increase a patient's risk for the development of perinatal depression. Next, we'll talk about perinatal anxiety, which affects 6% of all pregnant patients and 10% of all postpartum patients. Some patients will experience anxiety alone, while many others will experience anxiety and depression together. Symptoms of perinatal anxiety include constant worrying, racing thoughts, feeling as if something awful is going to happen, experiencing disturbances in sleep and appetite, having an inability to sit still, and sometimes even experiencing physical symptoms, which include nausea and dizziness. Risk factors for perinatal anxiety include a personal or familial history of depression, anxiety, and postpartum depression for these patients as well. Postpartum panic attacks and postpartum obsessive compulsive disorder, or OCD, are additional types of anxiety experienced by postpartum patients. Postpartum panic attacks are characterized by intense periods of anxiety and nervousness that result in patients feeling short of breath, maybe having palpitations, difficulty breathing, dizziness, and numbness and tingling in their extremities. Perinatal OCD affects approximately 3 to 5% of moms, and some dads are affected as well. Perinatal OCD is characterized by obsessions, which are often repetitive and intrusive thoughts related to baby, which the person experiencing it finds very upsetting, and compulsions, which are behaviors that the patient experiencing the symptoms has to do to help the obsessions go down. So it might be an inability to sit still, a need to be really clean, reorganizing things, counting things. Those are all symptoms of perinatal OCD. Last, we're going to talk about post-traumatic stress disorder, or PTSD. Approximately 9% of all women develop PTSD during childbirth or in the postpartum period. This illness is typically caused by a trauma during the birth or postpartum period, and the threat could be real or perceived for the patient to develop symptoms. There are some important things to note about PMADs. PMADs affect 1 in 7 women and 1 in 10 men. If one person in the relationship develops a PMAD, the other person in the relationship has an increased risk of developing a PMAD. Patients that experience an unplanned C-section, a baby going to the NICU, having difficulty breastfeeding, they are at an increased risk of developing PMAD. No decision is risk-free. There's risk of starting medication, stopping medication. Patients who stop their medication during pregnancy have a 70% chance of relapsing. Patients that are not put on medication, that increases stress to the baby and can decrease attachment postpartum, which also has long-term effects on the infant and family. When someone presents with symptoms of a PMAD, it's very important for them to know that it's not their fault, and with the right treatment, these symptoms will not be long-standing. Assessing patients is very important because that allows you to identify what their areas of need are and get them plugged into resources as soon as possible, whether it is therapy, seeing a prescribing provider like myself. There are a few things to note about PMADs. PMADs affect 1 in 7 women and 1 in 10 men. If one of the people in the relationship is experiencing a PMAD, it increases the risk for the other partner to develop a PMAD. There is risk to treating and there is risk to not treating. Recommendations for mild symptoms are to encourage therapy, and if they are on a medication, keep them on the medication. If the symptoms are moderate to severe, medication is recommended as well as therapy. Postpartum Support International has a great psychiatric consultation line. If you have questions about a particular patient, you can call and set up a consult, and the psychiatrist will call you and give you their recommendations. It's free. It's a great resource, especially when waits to see prescribing providers like myself can sometimes be 6 to 8 weeks out. The other thing that PSI has is several online support groups, which is a great resource, even not in COVID, but during COVID in particular. Mother to Baby is a great website where it has information sheets about all the medications, the risk to fetus or infant or through breastfeeding. The other thing that I encourage people with PMADs to do is to not just randomly research the internet. All of the research is there, old, new, everything. And many of the research that was done that initially said that there was a lot of risk to infants has not been able to be duplicated in subsequent studies. So it is very clearly delineated on Mother to Baby, which I highly recommend utilization of by providers. Like I said, this was just touching the surface of PMADs. If you have any questions, please let me know. Thanks.